Right.
Well, you hear it a lot. You're in surgery a lot, and you know, the nurse calls down from the floor, patient so-and-so, what you giving her doesn't quite seem to handle the pain. There's a lot of that goes on too.
Yeah. Well, yeah, and
My favorite is the in the emergency room because their doctor who's not on call.
Well, right.
As they just came out of surgery not too long ago on the floor. They can't get it, they hold their doctor, and then they come to the emergency room instead, saying, "The pain medicine I just had an outpatient surgery is worn off, and the Lortab's not working for me, and you need to do something for me."
And they use the street name.
Yeah, right. And they come and
the
they say,
dosage.
"I need some."
And the dosage. I need
Yeah.
some tin. It's not
Right,
that
exactly. But still, you know, and then I'm like saying to myself, well, your orthopedist should have taken care of this instead of you coming to my emergency department for something like this. And if this information was out there for their orthopedic surgeon or their spine surgeon, whatever, beforehand,
Yeah, you're right.
then it would save them that emergency room visit.
Well, and that's exactly what that podcast says from Dr. Trescott. Is she was actually a surgical patient herself, and you know they were giving Lortab, and it was the proverbial I've had enough to kill a small elephant,
Right.
and you know it has no effect on her. Well, it turns out that she was a non-metabolizer of the 2D6 pathway, so now that she knows that she needs to have a medicine that goes through a different pathway. So, you know, so if this patient comes in and, you know, is on Lortab, you know, now you know that like codeine, hydrocodone, etc., they're going through the 2D6 pathway, so you might be more inclined to start with, you know, a fentanyl or something like that. So, anyway, here's an example of one of the relabeling of opioids based off of genetic testing, and you know, this is an example of OxyContin. Hydrocodone actually became a more restricted drug as of 2 months ago as well. So, like you said, you know, there are more physicians just trying to go to Tylenol because, you know, avoid them getting on an opiate. But if there are people prescribing it in pain clinics, I mean, they're prescribing a ton of pain medications at a lot higher rates. And as it turns out, one of my neighbors used to work for the U.S. Attorney General's office, and then he started prosecuting pain doctors, and now he defends them. And when he found out what he was doing, it's like, look, Ed, I'm more than happy to speak for you at group, you know, in group settings, because he believes this is the ultimate, you know, for a medical legal defense position as well.
Yeah, why do they take them like Skittles? You know, it's because
Yeah, no, exactly. You know, you're exactly right. So, you know, there's a chart here that talks about, you know, the rising deaths associated with opioids. Okay, so if you do need to increase the dosage, okay, you have a defendable stance because this is a rapid metabolizer of this pathway. You know, so there. So when I was doing my research, I found this from the American Association of Pain Management, and so we'll just skip down to here. Okay, it says issues ranging from the scientific basis of efficacy, safe, and appropriate use to healthcare providers' fear of legislative reprimand for indiscriminate prescribing. Among the most significant of the controversies is the abuse and misuse of opioids, and their use has increased substantially over the last 20 years, along with the increasing mortality rate from these aberrant behaviors. Okay, so what I did is I dig a little bit more into the American Association of Pain Management guidelines. These are the 3 top clinical guidelines for prescribing pain. It says thorough risk assessment and stratification is appropriate in every case. You're supposed to weigh all risks and alternatives, and the initial treatment should always be considered individual. So that's exactly what we do. It goes completely hand in hand. Okay? Because
says everything except genetic testing.
yeah. So if I'm a pain physician and I do this on my patients, okay, I can, you know, 2D6 or 3A4, 2C9, whatever, you know, I can say that, look, you know, you're a rapid metabolizer, a normal metabolizer, and this is the dose we want to go on, or, you know, you don't metabolize well through 2D6, and that's why they're ending up in the emergency room after their case, okay? And, you know, it's costing a ton of money coming into the emergency room, you know, and, you know, you have better things to do than try to, you know, deal with someone after. So, and then, so what you can do is you just weigh the risks and alternatives, okay? So, you're a rapid metabolizer of the 2D6 pathway. I normally prescribe Loratab. Well, I may prescribe a different medication based off of this. It's going to go through a different pathway now. And now I'm going to know the pathways of the medications, because, you know, if I put you on Loratab and that's not working well, maybe I'll try you on hydrocodone. Well, that goes through the same pathway, so you're gonna have the same results. And so it's just an education process for the physician. So, I don't think it's going to take that long for them to, you know, get it. This data is a little bit old, but nonetheless, it's about the same. This is from the FDA about adverse drug reactions. So there's about 2 million serious ADRs yearly, resulting in 100,000 deaths, which is leading cause of death greater than pulmonary disease, diabetes, AIDS, etc. And there's about 350,000 yearly ADRs in nursing homes alone. So what happens when you go to a doctor's office? 2/3 of the patients end up with another script written. And, you know, like I said, we go back to that patient ID card, okay? So, you know, Dr. Risman has you covered today with the medications we prescribe. But if you go to another physician and they want to prescribe another medication, pull your card out with Dr. Risman's name on it, and, you know, make sure that they account for your genetics when prescribing another medication. So what happens is ADRs go up exponentially with 4 more medications. So is it clear now that, like, when you start if you have 4 drugs, or if you add a 5th or a 6th, you have greater chance of going down the same pathway to have that drug-to-drug interaction, which would cause adverse drug reaction. And they're costly. There's $136 billion per year. It's actually greater than the total cost of cardiovascular and diabetic care. That floored me. And this is from the FDA. And so it says the mean length, stay, and cost of mortality for the adverse drug reaction patients are double that for the control patients as well. So I think that even leads into more why it needs to be, you know, on the patient's medical record. So 2D6, like I said, that's that one pathway that metabolizes roughly 30% of the drugs, which includes opiates and beta blockers. So 70% of the actually Caucasian process this normally, but 30% do not. So once again, wouldn't it be nice to know this up front? So 2D6 for Caucasians. Caucasians only metabolize this normally 70% of the time. Well, 5% are going to be poor metabolizers. You're about 7 to 10% that will never metabolize. That's why they're showing up in the emergency room sometime. And then you have 5 to 15% that are rapid metabolizers that need that increased dosage. So African Americans, they drop down to 40%. And so I work in Atlanta, and I work with Morehouse, and when I showed them these statistics, that's when they had their aha moment, because, you know, they've been giving, you know, beta blockers for hypertension and things along that for years, and it's just not working. Well, 15 to 20% of African Americans don't metabolize through 2D6. So if I'm giving Coreg or whatever, it's not going to have the desired effect that we want, because they're just not metabolizing it. And then Asians, they metabolize roughly about 50% normally, but 45% of them have poor metabolizer status. And so with this next generation sequencing that AI Biotech does, we actually have data on, it's like 14,800 patients, and it's going to be published. They're submitting it for publication. But what they did is they actually put Latino in here as well. And you're going to have this information not only for 2D6, but 3A4, 3A5, 2C9, and 2C19. Good.
Ed, on the ID card, you've got the pathways, but you obviously don't have room for all the drugs and so forth.
No.
Is there a website on the card that can be accessed? They would show the drugs?
Well, AI Biotech has their website. Epocrates is the app, you know, for the physicians. We did actually, Tammy, why don't you explain you know, when we talked to Dr. Perry today?
Oh, yeah, she was kind of like, oh, she knew exactly about the Hippocrates, and she was looking at it, and he went through, you know, the whole scenario about the Plavix and the other drug. Is that what
Yeah,
we're
but then,
talking about?
you know, I'm
The
like,
Hippocrates?
just pick any drug.
Oh,
She
yeah.
typed in lisinopril, and I
Oh,
said,
yeah.
click on pharmacology. So it took, what, 10 seconds?
Not even,
In
Not
10
even
seconds,
10
she's like, oh, 3A4 pathway.
right.
So Hippocrates is free. It's one of the most commonly used apps for physicians, and you know, when you deliver this information to the physician, you know, let them know that, because what I did is when I delivered my first report, okay, you know, the first report kind of looked something similar to this, but a one-page report, and the doctor's like, Ed, I don't know 2C9 or what drugs go through 3A4 and all that, which no one's trained on all that. So like, okay. So I had to basically lock myself in a room for about a week and come up with this list of the different drugs with their corresponding substrates. The substrate is